So far in this module, we have discussed three major families of G protein-coupled receptors: adrenergic, muscarinic, and dopamine receptors, covering their receptor subtypes, G protein coupling, physiological functions, clinically important drugs, and therapeutic applications. To complete our discussion of the major GPCR families, we will now examine the remaining receptor types that are highly relevant in pharmacology. In this section, we will focus on their physiological roles, clinical importance, and pharmacological relevance, beginning with the histamine receptors. Histamine receptors are activated by histamine and regulate a wide range of physiological processes, including allergic reactions, gastric acid secretion, neurotransmission, and immune responses. They are classified into four subtypes: H1, H2, H3, and H4, each coupled to a specific G protein and producing distinct physiological effects. We begin with the H1 receptor. H1 receptors are coupled to GQ proteins and are widely distributed in vascular endothelial cells, bronchial smooth muscle, sensory nerves, and the central nervous system. Activation of these receptors stimulates the phospholipase C pathway, leading to increased intracellular calcium levels. Functionally, H1 receptor activation produces many of the characteristic features of allergic reactions, including vasodilation, increased vascular permeability, bronchoconstriction, and itching. From a clinical perspective, these effects are effectively blocked by H1 antihistamines. Drugs such as cetirizine, loratadine, and diphenhydramine are widely used in the treatment of allergic rhinitis, urticaria, and other allergic conditions. Next is the H2 receptor. H2 receptors are coupled to GS proteins and are located primarily on the parietal cells of the stomach, although they are also present in the heart. Activation of these receptors stimulates adenylyl cyclase, increases cyclic AMP levels, and promotes gastric acid secretion. Because excessive acid production contributes to peptic ulcer disease and gastroesophageal reflux disease, H2 receptor antagonists are used to suppress acid secretion. A commonly used example is famotidine, which reduces gastric acid production and is widely prescribed for the treatment of peptic ulcer disease and gastroesophageal reflux disease, or GERD. Moving to the H3 receptor, these receptors are coupled to GI proteins and are found predominantly on presynaptic neurons in the central and peripheral nervous systems. Activation of H3 receptors inhibits adenylyl cyclase and decreases cyclic AMP levels. Functionally, H3 receptors act as presynaptic autoreceptors, reducing the release of histamine as well as other neurotransmitters, including dopamine, acetylcholine, and norepinephrine. Because of their role in regulating wakefulness and cognition, H3 receptors have become important therapeutic targets in neurological disorders. Pitolisant, an H3 receptor inverse agonist, enhances histamine release in the brain and is approved for the treatment of narcolepsy. Finally, we have the H4 receptor. H4 receptors are also coupled to GI proteins and are expressed predominantly on immune cells, including mast cells, eosinophils, dendritic cells, and T lymphocytes. Activation of these receptors regulates immune cell migration, cytokine release, and inflammatory responses. Consequently, H4 receptors are being actively investigated as potential therapeutic targets for allergic diseases, asthma, atopic dermatitis, and other inflammatory disorders. At present, however, no H4 selective drugs have been approved for routine clinical use, and their pharmacological significance remains an active area of research. Next, let us examine the serotonin, or 5-hydroxytryptamine, 5-HT receptors. Serotonin receptors are activated by serotonin, also known as 5-hydroxytryptamine, or 5-HT, and regulate a wide range of physiological functions, including mood, sleep, cognition, appetite, gastrointestinal motility, and vascular tone. The GPCR serotonin receptors are classified into 6 receptor families. 5-HT1, 5-HT2, 5-HT4, 5-HT5, 5-HT6, and 5-HT7. These receptors are coupled to distinct G proteins, allowing serotonin to elicit diverse physiological responses across tissues. We begin with the 5-HT1 receptor. 5-HT1 receptors are coupled to GI proteins and are located in the brain, presynaptic nerve terminals, and cerebral blood vessels. Activation of these receptors inhibits adenylyl cyclase and decreases cyclic AMP levels. Functionally, they reduce neurotransmitter release, regulate mood and anxiety, and produce cerebral vasoconstriction. Clinically, sumatriptan and rizatriptan, which are selective 5-HT1 receptor agonists, are widely used in the treatment of migraine, while buspirone, a partial 5-HT1A agonist, is commonly prescribed for anxiety disorders. Next is the 5-HT2 receptor. These receptors are coupled to GQ proteins and are found in the central nervous system, platelets, and smooth muscle. Activation of 5-HT2 receptors stimulates the phospholipase C pathway, leading to increased intracellular calcium levels. Their activation regulates smooth muscle contraction, platelet aggregation, and several aspects of mood, perception, and behavior. From a pharmacological standpoint, many atypical antipsychotic drugs, including clozapine and risperidone, block 5-HT2 receptors and contribute to the management of schizophrenia and other psychiatric disorders. Moving to 5-HT4 receptors. These receptors are coupled to GS proteins and are expressed mainly in the gastrointestinal tract, heart, and central nervous system. Activation of 5-HT4 receptors stimulates adenylyl cyclase, increases cyclic AMP levels, and enhances gastrointestinal motility by promoting the release of acetylcholine. A clinically important example is prucalopride, a selective 5-HT4 receptor agonist that is used in the treatment of chronic constipation. The 5-HT5 receptor is coupled to GI proteins and is found predominantly in the central nervous system. Although its physiological functions are not yet fully understood, it is believed to contribute to cognitive regulation and circadian rhythm. At present, no selective drugs targeting 5-HT5 receptors are available, and these receptors remain an active area of research. Similarly, the 5-HT6 receptor belongs to the GS-coupled receptor family and is expressed primarily in the brain. Activation of these receptors is associated with learning, memory, and cognitive function. Although there are currently no approved drugs that selectively target 5-HT6 receptors, they are being investigated as potential therapeutic targets for Alzheimer's disease and other cognitive disorders. Finally, we have the 5-HT7 receptor. Like 5-HT4 receptors, 5-HT7 receptors are coupled to GS proteins and are located in the brain, blood vessels, and gastrointestinal tract. Activation of these receptors regulates sleep, circadian rhythm, mood, and smooth muscle relaxation. While no selective drugs are currently in routine clinical use, 5-HT7 receptors continue to be investigated as promising targets for the treatment of depression, sleep disorders, and other neuropsychiatric conditions. Let us now examine another clinically important family of G protein-coupled receptors, the opioid receptors. Opioid receptors are activated by endogenous opioid peptides, including endorphins, enkephalins, and dynorphins, as well as by opioid drugs. They play essential roles in pain modulation, mood and reward, stress responses, respiratory control, and gastrointestinal motility. Opioid receptors are classified into three major subtypes: mu, kappa, and delta. All three are uniformly coupled to proteins. We begin with the mu receptor. Mu receptors are coupled to GI proteins and are widely distributed in the brain, spinal cord, and gastrointestinal tract. Activation of these receptors inhibits adenylyl cyclase and decreases cyclic AMP, producing powerful analgesia, along with euphoria, respiratory depression, meiosis, and reduced gastrointestinal motility. Clinically, the mu receptor is the principal target of opioid analgesics. Drugs such as morphine, fentanyl, oxycodone, and methadone act primarily through mu receptors and are widely used for the management of moderate to severe pain. Next is the kappa receptor. Like the mu receptor, kappa receptors are also coupled to GI proteins and inhibit adenylyl cyclase, resulting in reduced neurotransmitter release. They are found mainly in the brain and spinal cord. Activation of kappa receptors produces spinal analgesia, sedation, dysphoria, and diuresis. Drugs such as nalbuphine and butorphanol exhibit kappa receptor agonist activity and are used for moderate pain, particularly in obstetric analgesia. Finally, we have the delta receptor. Delta receptors are likewise coupled to GI proteins and inhibit adenylyl cyclase, producing inhibitory neuronal effects. They are located primarily in the brain and spinal cord and contribute to analgesia, mood regulation, and emotional processing. Although no selective delta receptor agonists are currently used in routine clinical practice, these receptors continue to be investigated as promising therapeutic targets for chronic pain and mood disorders. Finally, let us examine the angiotensin II receptors, another clinically important family of G-protein-coupled receptors. Before we begin, it is important to note that angiotensin II is the biologically active peptide of the renin-angiotensin-aldosterone system, whereas angiotensin I is simply its inactive precursor. It is angiotensin II that binds to and activates the GPCRs. These receptors are classified into two major subtypes: the angiotensin II type 1 receptor, or AT1 receptor, and the angiotensin II type 2 receptor, or AT2 receptor, both of which mediate the physiological actions of angiotensin II. The AT1 receptor is coupled predominantly to GQ proteins and mediates most of the classical physiological actions of angiotensin II, whereas the AT2 receptor is coupled primarily to GI proteins and generally opposes many of the effects of AT1 receptors. We begin with the AT1 receptor. A T1 receptor is coupled to GQ proteins and is widely distributed in vascular smooth muscle, the heart, kidneys, and adrenal cortex. Activation of these receptors stimulates the phospholipase C pathway, leading to increased intracellular calcium levels. Functionally, AT1 receptor activation produces vasoconstriction, aldosterone secretion, sodium and water retention, and an increase in blood pressure. From a clinical perspective, AT1 receptors are important therapeutic targets. Drugs such as losartan, valsartan, candesartan, and telmisartan block these receptors and are widely used in the treatment of hypertension, heart failure, chronic kidney disease, and diabetic nephropathy. Next is the AT2 receptor. AT2 receptors are coupled primarily to GI proteins and are expressed mainly in fetal tissues, as well as in the brain, heart, and blood vessels. Activation of these receptors inhibits adenylyl cyclase and is associated with vasodilation, anti-inflammatory effects, anti-fibrotic actions, and tissue repair. Unlike the AT1 receptor, no selective AT2 receptor drugs are currently used in routine clinical practice. However, these receptors remain promising therapeutic targets for cardiovascular, renal, and neurological diseases. Before moving on to the clinical importance of GPCRs, it is important to remember that the receptor families we have discussed represent only the major clinically important GPCRs. In reality, the GPCR superfamily is much larger, comprising more than 800 receptors in the human genome. Many additional GPCR families regulate essential physiological processes throughout the body. For example, metabolic and endocrine receptors, such as the glucagon-like peptide 1 or GLP-1 receptors, and glucose-dependent insulinotropic polypeptide, or GIP receptors, are primarily coupled to GS, stimulating cyclic AMP production to enhance insulin secretion. Glucagon receptors are also GS-coupled, whereas somatostatin receptors are predominantly coupled to GI, suppressing hormone secretion. Thyroid-stimulating hormone receptors are mainly GS-coupled, stimulating thyroid hormone synthesis and release. Similarly, Neuroendocrine and fluid balance receptors include the vasopressin receptors, where vasopressin type 1 receptors are coupled to GQ proteins and mediate vasoconstriction, whereas vasopressin type 2 receptors are coupled to GS proteins and promote water reabsorption in the kidneys. The oxytocin receptor is also GQ coupled, stimulating uterine contractions during labor and milk ejection during lactation. Corticotropin-releasing factor receptors are primarily GS-coupled, regulating the body's response to stress. The body also contains several inflammatory and immune GPCRs. Leukotriene receptors are predominantly coupled to GQ and GI proteins, mediating inflammation and bronchoconstriction. Prostanoid receptors couple to different G proteins, including GS, GI, and GQ, allowing prostaglandins to produce diverse physiological effects. Chemokine receptors, such as the CC chemokine receptors and CXC chemokine receptors, are predominantly GI-coupled, directing immune cell migration during inflammation. Likewise, purinergic P2Y receptors couple to either GQ or GI proteins, regulating platelet aggregation, vascular signaling, and neurotransmission. Let us now examine the sensory G-protein-coupled receptors, which enable us to detect smell, vision, and taste. Unlike the classical GPCRs discussed earlier, these receptors couple to specialized G proteins that convert external sensory stimuli into intracellular signals. We begin with the olfactory receptors. These receptors mediate the sense of smell and are coupled to the olfactory G protein, or GOLF. Activation of olfactory receptors stimulates adenylyl cyclase, increases cyclic AMP, and initiates olfactory signal transduction, allowing the detection of odorant molecules. Next is rhodopsin, the visual pigment found in the rod cells of the retina. Rhodopsin couples to transducin, or GT. Upon light activation, transducin activates phosphodiesterase, decreases cyclic guanosine monophosphate, or CGMP, and initiates visual signal transduction, enabling vision in dim light. Finally, we have the taste receptors, which detect sweet, bitter, and umami tastes. These receptors couple to gustducin, or G-GUST. Activation of gustducin stimulates phospholipase C beta-2, increasing inositol 1,4,5 trisphosphate, IP3, diacylglycerol, DAG, and intracellular calcium ions, thereby initiating taste signal transduction. Beyond these are the developmental GPCRs, including the frizzled receptors, which participate in the wingless integrated, or WNT, signaling pathway. Frizzled receptors can couple to GI, GQ, and G12-13 proteins. Through these signaling pathways, they regulate cell fate determination, cell proliferation, migration, polarity, embryonic development, tissue homeostasis, and stem cell regulation. Dysregulation of WNT signaling has also been implicated in cancer. Another important developmental GPCR is the smoothened receptor, which functions in the hedgehog signaling pathway and signals primarily through GI proteins. Activation of smoothened inhibits adenylyl cyclase, decreases cyclic AMP levels, and regulates downstream hedgehog pathway effectors. These receptors are essential for cell growth, differentiation, tissue patterning, embryonic development, and organogenesis, while abnormal signaling is associated with cancers such as basal cell carcinoma. Finally, the protease-activated receptors, or PARs, couple predominantly to GQ and G12-13 proteins. Activation of these receptors increases inositol 1,4,5 trisphosphate, diacylglycerol, and intracellular calcium, while G12-13 signaling activates Rho-A-dependent pathways. Functionally, PARs regulate platelet activation and aggregation, promote blood coagulation, and mediate vascular inflammation and vascular permeability. With that, we have completed our overview of the major and additional families of G protein-coupled receptors. Let us now consider why GPCRs are so important in medicine and pharmacology. GPCRs, are the largest family of cell surface receptors in humans, with more than 800 receptors identified in the human genome. They are present in almost every tissue and organ and function as molecular signal transducers, converting extracellular signals into intracellular responses through G proteins and second messengers. These receptors respond to a wide variety of ligands, including hormones, neurotransmitters, peptides, lipid mediators, chemokines, and sensory stimuli such as light, odorants, and tastants. As a result, GPCRs regulate nearly every major physiological system, including the cardiovascular, respiratory, nervous, endocrine, gastrointestinal, immune, and sensory systems. Because of their widespread distribution and diverse physiological roles, approximately 30 to 40% of all approved drugs act by targeting GPCRs, making them one of the most important therapeutic target families in modern medicine. GPCRs have transformed modern medicine by regulating virtually every physiological system in the human body. By selectively activating or blocking specific GPCRs, drugs can restore normal physiological function and effectively treat a wide range of diseases. Let us begin with the cardiovascular system. GPCRs, such as the beta-1 adrenergic, alpha-1 adrenergic, and angiotensin A T1 receptors, play central roles in regulating heart rate, cardiac contractility, vascular tone, and blood pressure. In conditions such as hypertension, heart failure, arrhythmias, and angina, these physiological responses become dysregulated. Drugs that block or modulate these receptors help lower blood pressure, reduce cardiac workload, improve cardiac function, and decrease the risk of cardiovascular complications. Examples include metoprolol, prazosin, and losartan. Next, let us consider the respiratory system. Beta-2 adrenergic receptors produce bronchodilation, whereas muscarinic M3 receptors mediate bronchoconstriction. In asthma and chronic obstructive pulmonary disease, airway narrowing makes breathing difficult. Stimulating beta-2 receptors or blocking M3 receptors relaxes airway smooth muscle, improves airflow, and relieves respiratory symptoms. Common examples include salbutamol, tiotropium, and ipratropium. GPCRs are also abundant in the central nervous system, where they regulate movement, mood, cognition, reward, and neurotransmission. Alterations in GPCR signaling contribute to disorders such as Parkinson's disease, schizophrenia, depression, anxiety, and migraine. By selectively activating or blocking dopamine, serotonin, and opioid receptors, drugs restore neurotransmitter balance, improve motor function, stabilize mood, and relieve neurological and psychiatric symptoms. Examples include haloperidol, risperidone, sumatriptan, and buspirone. Pain perception is also largely regulated by GPCRs, particularly the mu-opioid receptor. Activation of these receptors suppresses pain transmission within the brain and spinal cord, producing powerful analgesia. Consequently, drugs such as morphine, fentanyl, and oxycodone are widely used to treat acute pain, chronic pain, post-operative pain, and cancer pain. Although highly effective, these medications require careful use because prolonged activation may lead to tolerance, dependence, and respiratory depression. GPCRs also regulate many functions of the gastrointestinal system, including gastric acid secretion and intestinal motility. For example, blocking histamine, H2 receptors reduces gastric acid secretion, helping to treat peptic ulcer disease and gastroesophageal reflux disease. Likewise, activating serotonin 5-HT4 receptors enhances gastrointestinal motility and improves chronic constipation. Thus, GPCR-targeted therapies help restore normal digestive function. Another major area of GPCR pharmacology is the endocrine and metabolic system. GPCRs regulate hormone secretion, glucose homeostasis, appetite, and energy metabolism. GLP-1 receptor agonists, such as semaglutide, improve insulin secretion, suppress appetite, and promote weight loss, transforming the treatment of type 2 diabetes mellitus and obesity. Similarly, dopamine D2 receptor agonists, including bromocriptine and cabergoline, reduce prolactin secretion and are used in hyperprolactinemia. Finally, GPCRs play a central role in allergic and immune responses. Activation of histamine, Rh1, leukotriene, and chemokine receptors contributes to itching, bronchoconstriction, vasodilation, mucus secretion, and inflammation. Drugs that block these receptors reduce allergic symptoms, improve airway function, and suppress inflammation. Common examples include cetirizine, loratadine, and montelukast. GPCRs provide highly effective therapeutic targets. This remarkable diversity explains why GPCRs remain one of the cornerstones of modern pharmacotherapy and continue to drive the development of new medicines. Having examined the major clinical applications of GPCRs, let us now understand their pharmacological relevance. Why are GPCRs druggable? GPCRs are considered highly druggable because they are located on the cell surface, making them readily accessible to circulating drugs. They also possess well-defined ligand binding sites, enabling small molecules, peptides, and biologic drugs to bind with high specificity. Another major advantage is that GPCRs regulate numerous physiological pathways while existing in multiple receptor subtypes. This allows drugs to selectively target a particular receptor subtype, producing the desired therapeutic effect while minimizing unwanted actions in other tissues. Agonists. The simplest way to target a GPCR is by using an agonist. An agonist binds to the receptor and activates it, producing a physiological response similar to that of the natural endogenous ligand. For example, salbutamol activates beta-2 adrenergic receptors, producing bronchodilation in patients with asthma, whereas morphine activates mu-opioid receptors, producing analgesia. Partial agonists. Unlike full agonists, partial agonists activate receptors but produce only a submaximal response, even when all receptors are occupied. Because they provide moderate receptor activation, partial agonists can maintain therapeutic efficacy while reducing excessive receptor stimulation and adverse effects. An example is buspirone, a partial agonist at the 5-HT1A receptor, used to treat anxiety disorders. Antagonists. Another important class of drugs is the antagonists. These drugs bind to GPCRs without activating them. Instead, they block the binding of endogenous ligands and prevent receptor activation. Examples include metoprolol, a beta-1 adrenergic receptor antagonist used in cardiovascular diseases, and cetirizine, an H1 receptor antagonist used to relieve allergic symptoms. Inverse agonists. Some GPCRs exhibit constitutive activity, meaning they possess a low level of activity even in the absence of a ligand. Inverse agonists bind to these receptors and reduce this baseline activity below its normal resting level. This mechanism provides additional therapeutic benefit in conditions in which excessive constitutive receptor activity contributes to disease. Allosteric modulators. In contrast to agonists and antagonists, allosteric modulators bind to a site different from the primary ligand binding site, known as the allosteric site. Rather than directly activating or blocking the receptor, they enhance or reduce the receptor's response to its natural ligand. This approach often provides greater receptor selectivity, preserves normal physiological signaling, and may reduce adverse effects. Receptor subtype selectivity. Many GPCR families comprise multiple receptor subtypes with distinct tissue distributions and physiological functions. Developing drugs that selectively target a single receptor subtype allows clinicians to maximize therapeutic benefit while minimizing effects on other organs. For example, selective beta-1 blockers primarily affect the heart, with less influence on beta-2 receptors in the lungs. Therapeutic index and reduction of adverse effects. One of the major goals of pharmacology is to achieve maximum therapeutic benefit with minimal toxicity. because GPCR drugs can be highly selective, they often possess a favorable therapeutic index, meaning there is a wider margin between effective and toxic doses. Advances in receptor selectivity have significantly reduced adverse effects and improved the safety of many GPCR-targeted therapies. For instance, look at penicillin. It boasts an incredibly high TI because it targets bacterial cell walls, a structure human cells completely lack. You can take doses well above the minimum effective concentration without approaching the toxic curve. On the other hand, drugs like valproate have a much more moderate or narrow TI. As our understanding of GPCR biology continues to advance, new therapeutic strategies are transforming the future of pharmacology. One promising approach is biased agonism, in which drugs selectively activate beneficial signaling pathways while avoiding those responsible for adverse effects. This strategy has the potential to yield safer, more effective, next-generation GPCR therapeutics. Another important development is allosteric modulation. Instead of binding to the primary ligand binding site, allosteric modulators bind to a different site on the receptor, allowing them to fine-tune receptor activity, improve receptor subtype selectivity, and reduce side effects. Advances in personalized medicine are also shaping GPCR pharmacology. Because genetic variations in GPCRs can influence individual drug responses, therapies can increasingly be tailored to each patient, improving both efficacy and safety. GPCRs are also emerging as important therapeutic targets in several major diseases. In cancer, they regulate tumor growth, angiogenesis, and metastasis, making them promising targets for anti-cancer therapy. In obesity, GLP-1 receptor agonists have transformed treatment by improving glycemic control, promoting weight loss, and reducing cardiovascular risk. Similarly, GPCRs are being investigated as therapeutic targets for Alzheimer's, Parkinson's, and Huntington's diseases, with the goal of improving cognition and reducing neuroinflammation. Finally, advances in gene and structure-guided drug discovery, together with artificial intelligence, are enabling the design of safer, more selective GPCR-targeted drugs. These innovations are expected to accelerate drug discovery and shape the next generation of precision therapeutics. With this, we have completed our discussion on G-protein-coupled receptors. Throughout this topic, we explored GPCR structure, activation mechanisms, G-protein signaling pathways, second messengers, the major GPCR families, their clinical importance, pharmacological relevance, and future therapeutic advances. As you have seen, GPCRs regulate virtually every major physiological system and remain one of the most important therapeutic targets in modern medicine. Continued advances in GPCR research are paving the way for safer, more selective, and more effective therapies for a wide range of diseases. I hope this topic has given you a strong foundation in GPCR biology and its significance in pharmacology. In Receptors Part 4, we will move on to another important class of cell surface receptors, the enzyme-linked receptors. We will explore their structure, signaling mechanisms, major receptor families, physiological functions, and clinical importance in health and disease. Thank you for watching, and I'll see you in Receptors Part 4.